So I'll start the recording first so I'm remembering that. Um, I think it started. Okay, and get my screen share up. Where am I? Okay, so hopefully you can all see that. So yeah, I'm going to be talking about the Jitsu Vax project today, and it's something that I've actually been sharing at TeDCog consecutive years since, I don't know, 2021. So some of this content may be familiar to some of you, but today I'm not just going to talk about the intervention that we've been developing in Jitsu Vax, but also how we've been embedding that practically into practice with the public and the health service along the way. So it's kind of not just the research intervention and the evidence around that, but also how are we making that practically useful to people. So a bit about the Jitsu Vax project to start with, if my mouse will work. Oops. Yep, there we go. So it's a project that's funded by the EU's Horizon 2020 program, and we span, I think I've got this right, 8 countries, 9 institutions. I keep forgetting because we grew a lot from the original set. And you can probably see from the photos, it's a very big team of people, and we are headed up by none other than Steve. So that's kind of why I've got this prime spot in TEDCog. Um, and whenever I start to tell people about this project, because it started in 2021, I always get a lot of nods and people going, "Oh, so is this about the COVID vaccines?" Um, but actually, vaccine hesitancy, which is what the project tries to address, is a problem that's been around for a long time before COVID. Um, Even before the pandemic, the World Health Organization already identified that this was one of the top 10 threats to global health. Um, and one thing that we know about it is that misinformation is the key driver of many vaccine misconceptions that people hold. And we've known about it for years, for decades. But COVID's a really nice example, actually, just to illustrate the costs. And I mean, I guess it's useful in the sense that people were doing a lot of research around it just because it impacted so many people. And so this is, as an example, a research that comes from Canada, which was estimating that vaccine hesitancy, which was fueled by misinformation, affected over 2 million people in the country, and it has associated health costs. So based on the assumption that if those people who believe that misinformation hadn't been exposed to it and therefore they hadn't therefore displayed vaccine hesitancy around it, researchers calculated that Canada would have seen 198,000 fewer cases of COVID. And that, of course, translates into fewer hospitalizations, fewer ICU, intensive care unit admissions. And that also means fewer deaths. And the monetary value they put on that was, I don't know how much that is in pounds, but nearly 300 million Canadian dollars. So misinformation, vaccine misinformation is a problem. Um, but we know that it's been a problem for a really long time. And so why hasn't there been a solution to it? Well, for a long time, the solution has very much been a very factual approach. And this is something we find very much in public health as well. So over the last year, I've done a lot of speaking with health professionals. It's actually quite hard sometimes to overturn their concept, which is just, no, we just have to give people the information. If they have the right information, they will change their minds, and they'll stop believing the misinformation. But from a psychological perspective, we know that doesn't actually work. So I think this is something this lab knows very well. Firstly, if there's no alternative narrative to replace the misinformation, it tends to stick in people's head. So this is what we call the continued influence effect, where even if you retract a myth, people continue to rely on it. And one of our reasons for that is that when you remove a myth from someone's head, it leaves a gap in there, and people's brains tend to try and fill the hole in. There's another reason as well that facts aren't really helping with solving this problem. And that's because sometimes the reasons why people don't accept those facts or that evidence is because it doesn't fit with their worldview. And I think one of the most striking examples of worldview consistent or worldview motivated rejection of vaccine evidence is seen in that graph over there. So that is a plot looking at the estimation of vaccine hesitancy across states in the across different states in the US. And so the blue states are the ones that tended to vote for Biden. So that's the Democrats. I hate the reversal of colors. It messes with me every time. All 3 years, I've always made that statement because I just always have to like switch around. So yes, blue, Democrat, red, Republican. And so you can see that striking pattern there. And you know, it's one of those graphs where you think, I wish my regressions all looked like that because that's a pretty nice line. But you can see that that higher vaccine hesitancy is observed among states that tended to vote for Trump versus Biden. And it's not that they don't have access to the same factual information put out by their health authority. It is about beliefs and whether the evidence is consistent with people's worldviews. And so one of the theoretical foundations of the approach that we've been taking is about people's motivations to reject science. And this was described in a paper by Hornsey and Fielding in 2017 about what they call attitude roots and jujitsu persuasion. So you might notice that that's where the jitsu part of JitsuVax comes from. So basically, they say that if people are motivated to reject science, you'll have very little impact if you reject evidence. And you can see from that paragraph there is that the issue of motivated science rejection goes beyond vaccination. It's about this overall tendency to reject science, about anti-science beliefs, including climate skepticism, including creationism. And so their conceptualization of an attitude root is something that lies under the surface and drives a specific expression of an attitude. So to put that in more concrete detail, JitsuVax is basically looking at the drivers of vaccine hesitancy. So looking at what's motivating it, motivating what people say about vaccines and what misinformation is out there before even starting to counter-argue. So we looked at thousands of these arguments against vaccines. And what we found was that they tend to cluster. So for example, you see on the left, there's a cluster of reasons that's related to the fear of adverse effects from medical interventions. So we kind of call them fear and phobias. On the right, there's a cluster of reasons that I'm sure most of you have an idea what these are. Usually if I'm delivering this presentation in person, I try and get people to guess. So have a guess in your head and you'll see if you're right. So we call that conspiracist ideation. So you can see that these tend to be about this tendency that someone's conspiring against the population in general. So we can kind of conceptualize the reasons that people are expressing, so all those little things in the boxes, as leaves on a tree, where the attitude roots go below the surface attitude that's being expressed, and those attitude roots kind of sustain the expressed reasons people are giving, even when you have facts and evidence, in the same way that roots might sustain and provide nutrients to leaves. And so our team kind of did a systematic literature review of all the anti-vaccination argumentation that was out there. We searched literature going back, I think the earliest might have been in the 1960s or even before that. And we kind of created a taxonomy or basically a hierarchical classification of different anti-vaccination arguments. And so to kind of make that a bit more concrete, you can see at the bottom we have individually expressed arguments. So for example, you've got some here about vaccine ingredients, and so we consider these as variations on a theme. And then there's another example of a theme on the right now where these are about the sort of injuries that vaccines can cause. And so these themes are clustered together under this attitude root that we call fears, or well, fear and phobias, I think I called it before, about the medical consequences that might come from vaccines. So through this whole process that I've just described, we distilled it down to 11 different attitude roots. And I'm not going to go through all of those in details because that could be a presentation in and of itself. But just to show how we've actually converted this into public-facing output, we actually have a website that we put together. So going from the empirical studies to a public-facing help tool. So this is kind of like a training guide and a web resource that has all of the different attitude roots with guidance on how you can use that in actual conversations or to understand more about how you can talk to patients or clients from the health service. And so this has actually gone into some of the health services sort of official, I forget what they call it, but it's like a training matrix thing where they hand out information to their staff. So attitude roots are kind of our foundation. because we care a lot about them as the psychological drivers that are motivating people's misinformed beliefs about vaccines. Attitude roots affect how we interpret incoming information. So as people, we just kind of have a tendency to reject information that we perceive as threats to our attitude roots, um, while tending to look for information that confirms our own beliefs. So because we know this and because we have this knowledge of vaccine attitude roots of vaccine hesitancy, we need to see how can our communication about vaccines align to it. And it's that sort of tailoring and understanding what's driving the person's motivation that led us to the second part of our research, which is this tool that we developed in JitsuVax. So it's basically a four-step framework that's laying out clear conversation goals and procedures. And we put it together first from a very wide background of disciplines, looking at research in communications, in psychological science, of course, cognitive science, public health practice. And one of the reasons for putting it together into a framework is that it makes it actually easier to teach people what we're doing about all of this. So remember, I am trying to show how this actually corresponds to how we're using things practically. So there's a lot of different pieces of research that suggest that something would be effective, but if we bring it all together, we can look at, right, how can it all fit together so that people can get this as a package? So I'm going to walk through these steps and explain the theoretical basis of this. The paper is there with that QR code if you're interested. And then I'm also going to walk through the evidence we gathered to make sure that whatever we're teaching this has some basis in evidence as well. So the foundational principles really are that one, it's based on attitude roots. I've talked already about how those are important and how they inform people's beliefs and willingness to be vaccinated. But there's a second foundational principle, which you might guess is in the name, and that is based on empathy, because we also know that if we're relying on healthcare professionals to be delivering this as trusted advisors, it's really key that you maintain trust. And trust is also a consistent predictor of vaccine hesitancy. It's found in so many studies, and we know that's really key. So building on those principles, why then are we looking at these four steps? Well, they kind of come from knowledge of what works against misinformation. And for some of it, it might be vaccine misinformation, but also misinformation more broadly. So I talked already a bit about empathy and tailoring. There is already actually this intervention out there called motivational interviewing. And it's sort of based on these principles of elicitation, so kind of finding out what matters to the person. So as you can see, that's probably very helpful if you want to know what's a person's attitude root. But it also uses other techniques. Basically, they're trying to build rapport and guide people towards change. And this has had some success with vaccine hesitancy, especially with people who are sort of on the fence. But one of the things that's kind of missing there is that changing of beliefs and the best practice we know from cognitive science, which doesn't usually talk that much public health. So we want to bring a little bit of that in. Now, another thing we know that works well is that if you ask people to try and explain their beliefs and they actually start struggling to do so, it can reduce certainty in those beliefs. And one of the things that we see is that overconfidence or unsubstantiated certainty in how much you know about vaccines is positively related to vaccine hesitancy. So the more sure you are of yourself when you're wrong, you also have stronger sort of beliefs in anti-vaccination concerns and arguments. So this is from a study from 2013. It's quite an old one, but basically they got people to try and explain the reasoning behind their beliefs. And then in the control group, they just did a different task. And you can see that there was only a significant change in how people basically judged how much they understood that belief before they tried to explain it versus after they had tried to explain it. So it's kind of reducing confidence. This is just another measure they took in that study where it looked at their extremity of their position. So this was basically how strongly they held those attitudes And again, you can see that decrease after people have tried and realized they can't really explain the rationale quite as well as they thought they could. So, third thing that we know works is the specific techniques used to address people's cognitive barriers to belief updating, so changing your beliefs with new information. I talked before about the continued influence effect. Fortunately, that removing that myth, although it leaves a gap, there are techniques to actually replace it if you have an alternative narrative that's plausible, that's salient, and explains why the myth is wrong. So a lot of Steve's prior work, you may know, has focused on this. That's a review paper I'm citing there by him and his and several colleagues, showing that these are the techniques you want to use if you're trying to correct people's misinformed beliefs. And finally, we do that facts kind of work because we see evidence that when you do sort of mass communication studies and you give people information that they read and engage with, it does change their views on vaccines. So there's a lot of this is in public health and that tendency to communicate over a population. We know it may not work specifically within a vaccine hesitant population just because they may come with those attitude roots that may not be addressed. But once you get people to a point where they're open to engaging with facts, we know that explaining the severity of disease can help, explaining how collective immunity really works, or you might know that term as herd immunity. It's basically the protection of the whole community by getting vaccinated. Explaining individual benefits also works. So this is when people are willing to consider the facts. So we put it all together in this four-step framework I talk about, and practically speaking, what it then looks like is you start with eliciting concerns, and this follows this kind of motivational interviewing approach where you're using open questions, so questions that elicit more than just a yes or no answer, and trying to actively listen to what the response is, like they're doing in the cartoon. And one of the goals is to just try and identify what sort of attitude route you're going on with, what you're dealing with here. The second step then still stays within that motivational interviewing approach, where we're really building up that empathy by doing something we call an affirmation. And that's basically a statement that's validating the person, just sort of acknowledging the truth in what they're saying, just really coming alongside and building a bridge, thinking about trying to bring someone along with you rather than combat what they're believing. So in this sense, aligning yourself to the attitude root and just reaffirming that attitude root, not necessarily the belief itself, but what the why of the person's belief is important. It's only then that we say, okay, right, let's move on to some of the best practices in psychological science when it comes to refuting misinformation. And here we advocate just really tailoring, still using that attitude root approach, working with the attitude root, not against it. And what we want to do is to look at those specific myths rather than the belief system. So, for example, if you have a strong belief that, oh, you have to do things naturally, it's not going to be possible to convince the person that, oh, well, no, natural is bad and you should just buy into vaccines. It's more of saying, right, how can we align vaccines with that whole belief in naturalness? Well, vaccines are stimulating, for example, your immune system to build up that natural sense of that natural way that the immune system works. So it's about here just explaining where that misconception comes from, why it's wrong, and giving a compelling alternative that can replace the myth and is aligned with the attitude root so it doesn't get rejected wholesale. And then, as I mentioned before, I talked about facts and the importance of these. And here we're looking at sort of best practice in science communication for how to provide facts or communicate evidence effectively. So some examples are to just really summarize complex evidence, use analogies, can use illustrations, basically try and demystify things so that people really get the information and can take it on board. So that's kind of the overview of how we actually develop the framework and put it together with practical considerations in mind as well. And now we're just kind of going from theory into practice. And what I'm going to do with this slide is give you an overview and a bit of a preview to the end of what will come in the next couple of slides. So I'm first going to go through some of the lab studies we did with vaccine hesitant participants, starting with a proof of concept study. where we kind of tested the empathetic refutational interview against different conditions where we didn't have the empathy, but we did refute myths, versus controls that take a very fact-based approach, just because that's kind of the usual approach people take, thinking that you just have to give information. And so the headline here is that there was more support from the ERI, and people were trusting the healthcare professional more and being more open to them when they use the ERI rather than the other methods. And then I'll talk about a follow-up study that was using animated video interactions that people watched. And here we tested it against the control. And also now we tried to bring in motivational interviewing. And again, you find improvements for trust and also increased intentions to vaccinate for the ERI versus the other conditions. I'll then move on into field studies where we are actually out there training healthcare professionals. Our first field test was in the UK, and headline findings, it was increasing their skills and confidence, and we are seeing them cascade the ERI training beyond what we initially taught them. I'll then talk about our second field test, which was in Romania, and this was training GP or family physicians if you're not UK based. And basically they tested two different versions of training, one condition where there was no training at all. And again, we see improved patients' attitudes and willingness for vaccination with the ERI. But also they were able to look at vaccination bookings, which is data that's pretty hard to get, especially in the UK. And ERI and motivational interviewing both saw some increase in vaccination bookings. Okay, so on to the details. So starting with the initial experimental evidence, so this is our proof of concept study. Basically, we conducted these experiments with vaccine hesitant participants. There was quite a few studies in this paper, but I'm just going to focus on one that has the full set of conditions. So people see a scenario where a patient states an anti-vaccination argument, and we use the ones participants believed because we were able to get that information beforehand. There are three different conditions. The first is what we call an active control condition. So people do go through a scenario, but here the doctor is just giving a very factual response, just telling them along the lines of, yeah, I know the recommended vaccine is safe and effective. That's why I recommend it, so on. We have our empathetic refutational condition, where the doctor gives an empathetic refutation that's tailored to the particular argument. So starting with an affirmation that says, maybe you make a good point, and then going on to refute the myth. And our final condition is just the doctor being very direct, just tailoring it to the argument, but just starting off going, nope, that's not true, that's a myth. This is actually what's going on, and then they do the explanation. And then our participants rate the doctor and their response. So I'll show you the results from 700 participants in this particular study. So the ratings were done on a 7-point scale. No colors. The colors are just kind of to help you wrap your head around it. They're a bit nicer to look at than the numbers. So we'll start with our control, which is a bit of our baseline. So you can see that 69% of participants here were in that range. I'm surprised about the 8% that were vaccine hesitant but were swayed by that, but you do get some people, which is why facts do work in some cases. But for the most part, no. And so you can see that the average is somewhere between 2 and 3, so that's pretty low. Our direct refutation, so that's just basically saying that's not true and explaining it in a way that's tailored. That does shift the dial a little bit, so you can see that there's more people either neutral or supportive of this response, and that's where how the average has moved. And then finally, well, it should probably come as no surprise because I gave you the summary before. We get the largest effect with the empathetic refutation condition, where you can see that the mean has shifted to pretty much being on the fence, but then the proportion of people supporting this explanation has increased drastically. So second study in the lab. This is follow-up experimental evidence using a video interaction. So previously I described one where people read it. In this study that was run by a very brilliant PhD student in Germany, That's her picture there, the first one. She basically worked with people to come up with these videos, and she had three different videos, a control video where it was a very fact-based approach. There's a motivational interviewing video as well. I won't show that here because I just want to focus on the control and the empathetic refutational interview. And I'm hoping the sound works because I'm going to play that and see if you can hear it.
It's important to immunize your child. If not, you're putting him in danger. Well, I know that vaccines protect children against several diseases that we don't see anymore. My child received all his first vaccines, but I'm worried that the MMR vaccine could cause autism. For other vaccines, I have fewer doubts, but I'm still hesitating. Well, your doubts are unfounded. Studies have demonstrated that there is no link between autism and the MMR vaccine. The vaccine is safe, I assure you. You should be aware of the information that you could find on the internet. We should update his vaccines now. Yes, I know it's a good thing to prevent those infections. But about the MMR vaccine, I'm conflicted. I've read a lot of books and articles. Lots of people are worried about the link between the MMR vaccine and autism. But you're putting him and other children who cannot receive vaccines in danger. The risks of diseases are much higher than the risks of vaccines. If I take this time to speak with you, it's because it's very important. We are talking about real dangers here. Sure, I know it is important. I am just worried. I'm worried about the fact that your child could get diseases that could be prevented by vaccines. There really is no reason to be hesitant about this. Again, studies have demonstrated that there is no link between autism and the MMR vaccine. The vaccine is safe. In fact, I am doing this for so many years now, and as a medical doctor, I can tell you that your concerns are unfounded.
Okay, so that's the control condition. You can think about it as you wish, and I'll compare it with the empathetic refutational condition.
What do you think about the advantages of vaccination? Well, I know that vaccines protect children against several diseases that we don't see anymore. My child received all his first vaccines, but I'm still hesitating. I see you are worried about this vaccine. Could you explain what worries you? I'm worried that the MMR vaccine could cause autism. For other vaccines, I have fewer doubts. It is normal to have questions and doubts about medical treatments and how they might affect us. The world can sometimes feel like a dangerous place, and we don't fully know why some medical conditions occur. It is understandable to want to know what caused a problem so we can try to avoid it or solve it. Yes, I know it's a good thing to prevent those infections. But about the MMR vaccine, I'm conflicted. I've read a lot of books and articles. Lots of people are worried about the link between the MMR vaccine and autism. If you agree, I could give you some additional information for studies on autism and MMR vaccine. Sure. I want to know exactly what happened. Fear and uncertainty can lead us to see connections that do not exist. In fact, people who have a reason to find fake links will often go to great lengths to publish false information. For example, in 1998, a doctor who was paid by personal injury lawyers published an article that falsely claimed a link between MMR and autism. After his dishonesty in science was exposed, the article was taken down. Since then, a lot of study has shown that vaccines do not cause autism. The article was retracted after his scientific misconduct was revealed, and extensive research has found that vaccines do not cause autism. What do you think?
Okay, so those are the two videos. Probably you can think yourself how you feel about it because that's kind of what the participants saw and had to rate. And so here's the result from that. And we can see that this is the ratings of trust in that physician. So you can see the control conditions quite low, but then for the ERI and the MI videos, people felt they could trust this physician a bit more. So that was great news, but also we also measured the intention to vaccinate the child after watching those videos. And it was a hypothetical child because it was basically a hypothetical scenario. But we can see here is where the ERI interaction was significantly outperforming the others. Okay, so those were the lab studies. Now I'm going to move on into the two field test studies I'll present today. And basically, this is kind of coming out of a very long year and a half of doing multiple field tests across the JitsuVax countries, where we were kind of concerned about, well, we know that the empathetic refutational interview is coming up, is producing results in the lab, but will it then, but to actually be able to do it, you have to train healthcare professionals who will be having these conversations to use the skills. Can training improve their skills and their confidence to have these conversations? What's their perception of using these? And what's the patient's perception of the conversation? And ideally, trying to get vaccine uptake. And so one of the challenges we have is because across different countries, it can be really hard to get this data. Yeah, in the UK, getting and linking vaccination uptake data is really hard just because of the disparity across sources and also the huge time lag in actually getting that data. But fortunately, other countries are able to step in with that. And so that's why I'm going to be showing you things across two countries, just because we could collect different things there. So the first field test was in the UK, and this is a great big thanks to the also very large team involved just to collect all this. And so I'm going to talk about two sets of training we did. So one of us was a very short training, which was 1 hour at the end of a day-long immunization program that's already being run. And we split participants into two groups, a control group that just went into their usual training setting, which was a program that had been running for about 15 years. So it's actually quite a high bar to clear this communications module. And we tested the ERI with a separate group, just giving them the presentation on the ERI, showing them some video demonstrations, and taking them to scenarios, practice those skills and pretend to have conversations with each other. Our second workshop training that I'm talking about was a training workshop where we trained people to then go and train other people. So this had a bit of more of a deep dive presentation. It was 2 days because, well, they really needed to get to grips with this to understand it enough to teach it. They had exercises, just really getting them familiar with the attitude roots, going through skills practice for each of the 4 steps I talked about. There was also video demonstrations and just repeated skills practice to get people really good at this. And so we're primarily interested in the skills and confidence that the healthcare professionals would get from this. So we measured them before and after the training, looked at how at their confidence levels, how well prepared they were to then rebut anti-vaccination arguments, how well they understood the skills. And we also followed them up at 1 month and 3 months after the training. Lots of attrition there, as always happens when you email people follow-ups. We also invited people to do qualitative interviews so we could understand their experience. So I'll talk about results in the first training, and I'm just going to focus on the preparedness to rebut the arguments before and after, and at the 2 follow-up time points. So we could see here that actually there's not much difference between the groups. The control group increased their preparedness so that the treatment group. So the best we can say here is, I mean, we think that mainly it's really hard to disentangle the general training effect, because remember that this came in at the end of a day where they had been already learning about vaccines and increasing their knowledge and getting a better overall base of knowledge throughout the day. And the control group actually did a vaccine communications discussion session as well. So from that perspective, it's maybe in a sense to know that it's at least as good as a 15-year-old program that's been running all this while. But of course, a little disappointing that we don't find additional benefits to that. We also looked at the train the trainers workshop, so we can see significant increases in people's preparedness to rebut the arguments. We also see the same in their confidence to be able to conduct an ERI in the field. So that was all great. But then with the train the trainers, we could also follow up to see, well, what did the trainers go on to do since then? And so like qualitative, follow-ups with them, we know that in the London borough of Hammersmith and Fulham, they've actually gone on to do 7 workshops over this year already with 65 people in the borough. And these include local community leaders and frontline health professionals. So that's kind of gives you an inkling of how this sort of thing can be cascaded, because there's only so many researchers that can go around who could do the training. One of the interesting things in our conversations with them was that they were talking about attendees in their training who came in hesitant and then left feeling more convinced to get vaccinated, but also advocate for vaccinations. So that was very interesting data for us. So two other examples there, because this has been going over this year, some of our trainees are at a later stage planning training themselves, but we also know of multiple smaller sessions that have been conducted since as well. So it's quite promising evidence about that cascade effect. And so I'll finish off with the second field study in Romania, and this is the team that was involved in leading this. And so in Romania, they had three groups of recruits, healthcare professional recruits. So the control group got no training. The ERI group got 1 day training, which was 6 hours of ERI training. And then they also compared it to a motivational interviewing group, where there was 1 day training, again, 6 hours. And so the training groups got pre and post test evaluations of their knowledge and skills and confidence. And the headline here was that they did report significant improvements from the training. So the training was working in a sense. But what's interesting is what comes after, because this builds on where we were able to get to in the UK. The practice staff then had counselling sessions about vaccination. So there it was either HPV, the human papillomavirus, or the influenza vaccine. And they were targeted to do a minimum of 10 hesitant patients each. But they actually managed to get quite a lot of data. I don't know what that says about vaccine hesitancy in Romania and the prevalence of it. But basically, the patients filled in questionnaires before and after their session. And the team also interviewed GPs after all of these interventions to get a bit of qualitative data. So what I'm going to focus on here is the change in patients' attitudes. So from that patient questionnaire. And you can see that actually all of the groups increased, even the control, interestingly enough. But what you can see is that actually pre-test, the ERI group had the highest hill to climb and did manage to get that higher increase as well. Willingness to be vaccinated, again, you saw the biggest increase in the ERI group, which again, they did start from a lower baseline, but the interview did change those attitudes more. And then the practices also reported the number of vaccine appointments booked post-training, and there was 20% more in both the groups that received training relative to the control. And an interesting thing to finish off with this study is that there was no significant difference in terms of patients' satisfaction with their interaction with the GP. So we think that's an interesting thing to note, because fundamentally the ERI does recommend challenging patients' misconceptions. So you might say, oh, maybe that might produce lower satisfaction compared to, say, MI, which is a bit more of a empathetic only and not actually going into the misinformation part of side of things. So we're actually quite pleased that it's not actually producing counter effects in terms of how people feel about it. So back to that summary, I will reiterate, basically in the proof of concept study, we found that the ERI got more support and participants trusted the healthcare professional more. They were also more open to listening to that healthcare professional. In the video study, we saw more trust in healthcare professionals with a healthcare professional that used an ERI approach and also a motivational interviewing approach, but it was the ERI that increased people's intentions to get vaccinated. In the field studies, we mainly saw increased skills and confidence in the UK and a cascade of ERI training, with so far we are reporting qualitative difference in the communities that are getting this training. And finally, the field test in Romania saw, again, improved patients' attitudes and willingness, and increases in vaccination bookings for the practices that receive training. So altogether, this is starting to build us a base of evidence to say that the empathetic refutational can give a better chance to correct misconceptions and increase vaccine acceptance, while still maintaining trust in that overall relationship, which is something that's really important when you're in the field. Um, so yes, I will end here. Thank you very much, and I'll leave it open to questions then.
Thank you very much, Dawn. Happy to say that I'm not alone anymore. So,
Hello.
so I'm Fabio, by the way. Rolling, nice one. Nice to meet you. So because I still don't know the students in this year. So yeah, thank you very much. So yeah, we can. I mean, I don't know why I'm moderating. Technically, it should be you, but
Well, it's a little bit weird to moderate myself, and actually, I think it was supposed to be
that's true.
Christoph, but he's not here. So, um, but yes, if anyone's got any questions, comments, please do. Uh, you can raise your hand, just speak directly, or put something in the chat.
I have a few questions. Maybe okay. No, let's start with questions.
You've cost us the chance.
Yeah.
Yeah, I got the opportunity. So I have a question in regards to the difference between countries. So you have some countries that might have a little bit higher trust in institutions and interpersonal trust on average, and other countries where maybe this is not the case. So could you like I don't know, test to see if there's an effect, a moderating effect of this factor?
So do you mean within the countries or between countries?
Between.
So it's a little bit hard to actually test between countries because we don't have the same data. Like we don't have patient data from the UK. So we can't really see how the patients respond until much later. So the problem with the UK is that vaccination data is published on a lag. And it's really hard to get to work with individual GP practices. Like you need half a thousand like individual contracts with all of these different ones. So it's quite hard to do. So if the trainings only happen now, it will be maybe 2 years before we have any data, and it will also be really hard to isolate what happened. So that's why, yeah, we can't really compare.
So at the individual level?
Sorry, at the individual level?
So then at the individual level, if you measure, did you measure like interpersonal trust or something like this in the beginning or at the end?
For the healthcare professionals, you mean?
No, the first part of the studies where you had like people, not the healthcare professionals, I mean the
lab
patients.
studies.
Yeah.
So the lab studies were all done in the UK, so I can't really oh no, there was a US one as well. So we could look at that as a moderating variable between countries, but again, they were in different sub-studies, so you can't really compare like for like there. However, we did have trust as a covariate, and it was so it was a significant predictor of people's vaccine attitudes, willingness, but it didn't interact with the various conditions.
Okay.
Yeah.
Thanks.
Alan? Oh, hello.
Hi there. Thanks very much for the talk. My question is maybe a little bit speculative, but at the start you said that the idea of the attitude roots was kind of about kind of anti-science views more generally than just the vaccine hesitancy case. So that did lead me to wonder whether you suspect that the kind of interventions that you're trialing here would work in broader range of situations as well. So not just in vaccine hesitancy cases, but in kind of climate denial situations, or even more broadly than that. So kind of disagreements or misperceptions that aren't necessarily about science, but about just disagreements more broadly. Is there a suspicion that that would work, and is there an ambition to roll this out in
Yes.
increasingly broad ways?
The short answer is yes to all of that, in that we've actually heard this even from the healthcare professionals who attend the training. They start asking us, oh, will this work with the drug and alcohol problems, or can we use this in other cases? And I always have to tell them I cannot say anything that's not evidence-based, so I have to say we haven't studied it, but it'd be lovely if you could try it and tell us what you see, because that's our data point. yeah, it's I mean, I can tell you anecdotally, it works very well on in-laws. Um, but yeah, and there's definitely that ambition. So I think there's a lot of discussions I've been having with Steve about can we put in grants to try and expand this outwards, looking at climate change, but also um, other areas of scientific misinformation. I mean, to start with, because it's a lot easier to do the research when you have a ground truth. It gets a bit more tricky if you're looking at things where there isn't a confirmed position, where there's no evidence on it, because then it's about receptiveness. And there's I mean, I can probably send you the links if you're interested, but there's a wider uh, base of research around conversational receptiveness, so kind of improving people's dialogue around contentious issues. I suspect that the initial parts of the conversation might help, but then if there's no real way to debunk a myth, it might be harder. But that doesn't mean that you can't get into social issues with it. For example, say the one that's coming to mind now is say like migration. There's a lot of myths around that, and that is actually debunked by statistics. Um, but then I think that it's not scientific statistics, but it's actual fact. So I feel like this could be relevant there, and I would love to explore that more. Just thinking because people have very deep-rooted beliefs that inform how they think about migration and whether they think it's too high or too low, or indeed whether they riot about it. Yeah, a lot of that stems from emotional and attitudinal components rather than, yeah, people aren't looking at the evidence when they decide to protest violently outside an asylum seeker hotel. Uh, so that wasn't an evidence-based comment, but I'm fairly willing to back it up with money. So yeah. But yeah, I hope that answers your question.
Yeah, very exciting. Thanks very much.
Yeah. We do even have students in this group who are hoping to look at this in their dissertation projects with different areas as well. So I think political behavior and gender quotas are the things we've been discussing with them. So that's quite exciting.
Sounds great. Thanks very much.
Thanks, Alan.
Hi, Dawn. I do have a question similar to what Costas asked about. Do you know if there's a sort of mediating effect of the attitude belief related to the refutation effect? So I would expect if my core attitude is conspiracy, I'm more on the fence, like or something like that. So or does the refutation works equally across, regardless of my core belief?
Yeah, I did actually try when we had that data to look at whether we had any effects on the basis of which attitude route we were targeting. So basically, the scenarios people saw were all tailored to whichever belief that they were holding. And so I suspected the same as you, but I couldn't find any consistent effects of the attitude routes. And so my only conclusion there was that actually there's nothing. Maybe we just don't have sufficient power because there's 11 of them, which is, you need quite a lot to be able to disentangle that. But yeah, I couldn't find any consistent effects. Okay, I think that might be it for questions, but do shout if I've missed you out. Well, if not, I guess thank you all for coming. We do have a professional development session that follows straight after this, and this is mainly for the benefit of our students. And the focus today will be on research project management, so maybe that will be of interest to you as well, because I'm really keen for some of the more senior researchers to be sharing their experiences as well about the pitfalls and things you ought to think about just to make this as useful for our students as possible. But of course, understand if you've got to go. So thanks again. Next week, we're going to be having Fabio, I think. So yeah.
Yes.
Oh, yes, Theo.
Oh, hi, sorry, I was just looking for the function to put my hand up. Great presentation. Dawn, thank you for sharing. I was just wondering to what extent you build upon these relationships. So the premise being that you're building trust, and that's for a one-off medical intervention in this case. And to some extent, you answered the question, and Alan mentioned how could this be developed upon, and then a question which I suppose I'm thinking about is to what extent do you see that actually the training resides around listening and training people to be more receptive in regards to understanding what their patients' needs are, as opposed to just responding or reasserting the science as far as they know it, and to actually being more empathetic in that approach. And I don't know to what extent that's been considered with regards to just listening as the focus.
Yeah, so I mean, I think that our comparisons with the motivational interviewing approach probably answer that the most, because motivational interviewing is very heavy on the listening and not actually putting forth what you think. It's always just guiding and just eliciting what the patient wants out of them. And there's no like debunking really taught in as part of motivational interviewing. Whereas we've got more of that misinformation component. Um, so I think for us, the issue is that you can't really with some of the vaccine misconceptions, it's really hard to just stop there at listening and affirming, because you could go on and say, oh yeah, I'm listening to you, and yes, 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 that's all right, yeah, it's all great. So yeah, you build a really good relationship, but then you don't do anything about the actual myth. So you could end up with a situation where the person goes away thinking, oh yeah, the healthcare professional agrees with me that vaccination is bad, which again, healthcare professionals are very worried about. So you start teaching them these things and they're like, they do actually find it difficult to acknowledge the truth in what people are saying, even though that misinformation does always stem from a grain of truth. Um, because there's this fear that you're going to be endorsing misinformation yourself.
Appreciative. Yeah, it's that inquisitive approach with being able to turn it around so that one has permission to share that space. But yeah, fantastic piece. So thanks for the presentation.
Thank you. Okay, Fabio, do you reckon we should move into the professional development side now?
Yes, I think we should stop recording just for the.
Yes, where is my button? Sorry, my presentation's still